Welcome to a new episode of the Prevention Leaders Podcast, where today we're diving deep into the realms of mental health and effective communication. I'm thrilled to introduce our special guest, Dr. Emily Klein, an assistant professor at Boston University and a leader in the Psychotic Disorders Clinic at Boston Medical Center. Dr. Klein brings a rich tapestry of experience in clinical psychology, psychotherapy, and what I happen to think is most intriguing, the art of motivational interviewing. And in our conversation, we'll explore Dr. Klein's groundbreaking work, particularly her innovative program, the School of Hard Talks, which is revolutionizing the way parents and caregivers communicate with adolescents that are grappling with mental health and substance use challenges. I want you to expect to hear some compelling insights, some heartwarming stories, and practical strategies that can transform the way we all communicate in challenging situations. So sit back, tune in, and get ready for an episode that promises to enlighten, inspire, and empower you in ways that you have never expected. So let's get started. All right, podcast listeners and watchers, here we are for another episode. And I'm so excited to welcome Dr. Emily Klein to the episode. Welcome.
Hi, thanks for having me, Dave. I'm happy to talk to you.
Hey, I have been looking forward to this chat ever since Steve at the PTTC and the Prevention Perk is like, hey, you got to talk to this gal. She got this School of Hard Talks and talks MI with parents and all this stuff. And as soon as he said MI, my ears perked up. And I know we'll get into that, but could you just kind of introduce yourself? Where in this world are you located and what do you do?
Sure. So I am in Boston. I am a clinical psychologist. So that means that I do a couple different things. I'm an assistant professor at Boston University. So I work at the university hospital, which is called Boston Medical Center. I help to lead the Psychotic Disorders Clinic. And that is a big multidisciplinary team of doctors, nurses, psychologists, social workers, and we have some peer counselors who are sort of experts by experience as well. So that's kind of one hat that I wear. I am a teacher, so I teach a lot of people how to do psychotherapy, and I teach a lot of non-therapists how to do motivational interviewing. So I work with lots of different people who are interested in learning these skills. And I'm also a clinician. I see my own patients and I do my own assessments and evaluations. And I'm also a researcher and a writer, meaning that when something strikes me as a burning, interesting question, I'll dive into the literature or I'll even get a grant to do my own study and share those results with people when I figure it out.
Ooh, okay, I'm coming back to that researcher because I have a question. But first, prevention pros that are listening, sound familiar? Wearing about 16 different hats and having to switch roles and hats all the different times. Oh my goodness. So how do you manage it all? Give us some wisdom there. How do you handle wearing all those hats?
I actually have a pretty developed philosophy around this, which sounds a little bit silly, but I realized very early in my career that I could never be on top of everything, but I could be very, very present to the person in front of me and just try and completely compartmentalize, leave it all at the physical door or metaphorical door if we're talking on Zoom, and just focus on the meeting that I'm in or the patient in front of me or the podcast that I'm recording, and try and leave it all. If everything else is a mess, that is a then problem. Right now, I'm enjoying whatever I'm doing. And I usually do enjoy whatever I'm doing in the moment.
The power of presence. Yes, indeed. Okay. That's actually a conversation I was having with my therapist last week, talking about my challenge of really being present and quieting my mind so I can be present and feel and explore and enjoy my emotions. But that's a whole nother episode there. Sorry.
You should have your therapist on.
Right. I know. Oh my goodness. Yeah. But luckily, I didn't get lost in the moment. I remembered that question. I want to know more about being a researcher. What what questions are you exploring, or what are you looking into right now?
Well, so I did my PhD at the University of Maryland in Baltimore County, which is a very sort of research heavy program. And I've been doing psych research for about 15, 16 years now. And in that time, I've gotten to look at all kinds of interesting questions. And I've worked on some studies I'm really, really proud of. And I've worked on some studies which I won't talk about on this podcast, which turned out to be not that interesting to do, or the methods were so flawed that I was like, what are we going to learn here anyway? So there's all kinds of research, but some of the things I'm most engaged with right now are really figuring out the relationship within my psychosis clinic between symptoms of psychotic disorders like schizophrenia and bipolar disorder and cannabis use. That's one of sort of my main research interests right now. And then also figuring out how do we talk to people about behavior change, which, MI is at the heart of it, but there's so many wrinkles to that. MI being motivational interviewing for those who aren't in the know yet. But there's so many wrinkles to that. Like, how do we train people in effective ways? How do we have the most impactful conversations with people who are really struggling with different kinds of behavior change? And that behavior change could be anything from, reducing their cannabis consumption to taking the medications that their doctors are recommending to hitting the gym, and those are all things that I would say within the families and patients that I work with are like three major issues. So how do we get people to actually make those changes?
Fascinating. And rather than really dive into your research, we'll save that for a future conversation. But I don't know, I might be reaching a little bit, but I see a common thread there in that when you bring MI, you bring the research, you like to ask powerful questions and you like to explore those questions as well.
Oh, thank you. That's a very kind frame. I sometimes think of it as the relentless churn of living inside my own head. But in a kind and generous framing, yes, it's exploring powerful questions.
Yes. Yeah. Right. Well, I know you talked about sort of your PhD work and what kind of led you down this path?
So my PhD work was actually in seeing whether it would be possible to diagnose schizophrenia at an earlier stage of illness. So this is a little bit in the weeds, but I'll just get into it because people might find it
Yeah. Yeah.
interesting. Typically, we use the diagnostic criteria for schizophrenia means that you've had these symptoms of psychosis, like hallucinations, seeing or hearing things that other people don't see or hear, or delusions, like feeling that people are after you or having other sort of beliefs that are causing you a lot of distress and disruption that don't seem to be true. Um, and negative symptoms like withdrawing from social life and work. And you have to have had those symptoms for at least 6 months before we would even think about using a label like schizophrenia. And that's for a really good reason, right? I mean, that is a highly stigmatizing diagnosis. I think we should use it really cautiously. And also the treatments for schizophrenia, which can be really, really effective, but we should use them cautiously. The first line treatment is medication, can have significant side effects. So if you don't really, really need it, shouldn't be taking it. So the question was prevention, right? Can we diagnose this disorder or figure out at least who's at risk at an earlier stage, depending on sort of how people are experiencing symptoms and how they're presenting. So typically when somebody has a disorder like schizophrenia, or the other disorder that we see a lot is called bipolar 1, where somebody, when they're really at the height of their manic episode, they'll have some of those same psychotic symptoms that you see in schizophrenia. So usually the average age of onset for those is 21. So like half before, half after. But we just see this peak around like 15 to 30 tends to be the age group that I see in my clinic. And the question was, what is going on in these young adults or adolescents' lives in the couple years before they see me, right? Like if we can walk backwards and sort of roll back the tape, what would we see? And could that be helpful for prevention? And there's a lot of, I'm not going to say this is like a winning story. There's a lot of sort of blind alleys and dead ends in when you start to roll back the tape because you're like, well, what behaviors are significant? Or, maybe this seemed like something, but it's actually something all kids go through. And so it doesn't really indicate any kind of highly predictive risk that's worth labeling. But there's certain things that do seem really relevant. And one of those is, I would say one of them is social engagement with friends and family. So we want kids to have a strong social support network. And if that falls out, that's cause for concern. And the other is substance use, in particular, cannabis and amphetamine, meaning like Adderall. So those are the things that I think are really significant for prevention. And so that's what I was initially studying in my PhD. And in the sort of 10 years since I finished that, I've worked in lots of different capacities kind of pursuing those, but really interested in strengthening social supports and relationships for adolescents and young adults, and also addressing substance use or preventing substance use if we can.
And if you haven't yet, check out the episode where I chat with the team from Wired Biohealth. I feel like y'all would have fun talking about the neuroscience, the epigenetics, and the DNA markers that they've identified that are mapped to mental health and mood disorders too. But that's all way above my head. But what
I will
isn't
check
is
that out. Yeah, I've listened to about half that episode so far, Dave, and it's just really interesting to hear what my colleagues in industry are working on, because in academia, we move really slowly and cautiously, but people are like taking big swings out there in the world, and it's very cool. It's very cool to hear about.
Yeah, absolutely. And if you want an introduction, let me know. Happy to make that happen. But so that neuroscience, all that is way above my head. But what isn't is motivational interviewing and substance misuse prevention. So I'd love to hear your MI story. How did that get started and what do you got cooking?
So I studied MI in graduate school in one of my classes that was taught really by sort of one of the, I guess, bigwigs of that kind of generation of MI and substance use researchers. So my professor was Carlo Di Clemente, who was, very involved in that world and helped kind of create what we think of now as the stages of change theory of the trans-theoretical motivational theory, stages of change. But basically, which is a really fancy way of saying that motivation is not an on or off, black and white thing, that people move through stages of change. And most of us, when it comes to any change, but especially a big change like substance use behaviors, are always a little bit 2 steps forward, 1 step back. That's a really simple way of kind of describing that stages of change theory. But I learned it in graduate school. It wasn't my specialty. I was really deep in the weeds of like schizophrenia literature and, like you're saying, genetics and risk and prediction models. But then when I finished graduate school, I started actually treating patients. And I realized that I had all of these like big manuals, treatment manuals, things. And a treatment manual, it sounds like it's there to help the clinician. But in my experience, very often, it's like a checklist for the therapist, things you're supposed to do. And I found that really, really difficult. I couldn't get my patients to march through these manuals with me. I just couldn't do it. And I didn't know whether that meant that I was like a bad therapist or my patients were like particularly stubborn and intransigent. But I just found these highly manualized, sort of worksheet driven, million-step checklists impossible. I couldn't do it. I couldn't get my patients to do it either. And I found that the one thing that I learned in graduate school, not the one thing, there's many, many super useful things I learned in graduate school, but motivational interviewing really quickly rose to the top of my toolkit as something I would grab all the time when I hit a dead end. Because basically, let me make this concrete for you. So imagine that you're sitting with a teenager who like won't go to school, is smoking a ton of weed, really the relationship with the parents has really degraded and corroded where like everybody's just so tense and resentful and suspicious of each other all the time. And you diagnose this child with something like depression. Okay. Now I'm supposed to bring out my manual that's sort of depression oriented, and start with, okay, let's open our books today, session 1. You think this kid's gonna be into that?
Right? It's like a worse version of school.
Exactly. It's a worse version of school. And it's so hard to do. So I would hit that dead end right away. And I'd be like, okay, good, we got that over with. But I have something for this, which is the concept of sort of rolling with resistance. And we learn in MI that when you hit that wall of resistance of somebody who goes, I'm not doing that, that's dumb. We don't have to give up and say, okay, then it's not a good fit. Good luck with your mental illness. We can say, oh, this feels dumb, or help me understand where you're coming from, or it feels like it doesn't seem helpful to you. Help me understand that. And we now have a new conversation, a new alley that we can go down rather than just saying, okay, well, I guess this isn't going to work out. So, I mean, you can see how immediately that became the go-to tool in my toolkit. And then I would be getting these calls and visits from the parents, of course, who are like, cannot sleep, absolutely melting with anxiety about their child, very understandably so, because their kid is really in a lot of distress and is not functioning like they used to. And they're calling me and they're like, okay, how do I get them to, accept this invitation to a birthday party, or take the medication that their psychiatrist recommended, or take a walk with me, get out of their room, take a shower. And I realized that, my go-to is motivational interviewing. Wouldn't it be a service to share these skills with the families, right? Because I'm in the room with this kid for 50 minutes once a week, but the parents get all the rest. And so that was kind of my idea, to share these skills and train non-professionals to use motivational interviewing in their encounters with individuals who might be struggling.
Mm-hmm. We're gonna talk a lot more about this because it resonates oh so well in many different levels. One of the things that I like to talk about when I took MI out on patrol with me is I was bringing the evidence-based approach to the student rather than waiting for them to come to us. And talk about just a force multiplier, expanding the reach, expanding the impact, and empowering those students. And you're empowering those parents as well. You're taking the MI to them, meeting them where they are. I love it.
Well, there's this saying that I'm sure you've heard, like, never let a crisis go to waste. And I love that idea that you're talking about of training, your own experience using this as a police officer and training others to use it, because you are encountering people at a moment of crisis, whereas I'm for the most part, in my office, right? And like in the hospital. I mean, if you could see where I work, it's literally this like back wing of the hospital. So people really have to find us. But there's settings like in an encounter with a police officer, or at school, or in the emergency room, where people are all of a sudden maybe in a space to grapple with a crisis. And if you can meet them at that exact moment, I mean, that's just such an opportunity. Because in my experience, motivation is like this window that cracks open for a golden hour. And then if you fail to notice or take advantage or be available, it's gone. And I mean, I'm not saying that I should then be on call 24/7. Like that's not a sustainable lifestyle, but how do we get people like you out there to notice those cracked windows and send a flare through them or whatever the metaphor would be.
Right. Right. I mean, what better time to have a conversation with somebody about their behavior change when they're already thinking about it? Yeah. I call it the life goes on time gap. And how that showed up for me is, a student would get a student conduct code citation on like a Friday. There in the moment, it's the worst thing that's ever happened to them. Oh my gosh, my life is over. My parents can be disappointed. I'm getting kicked out of school. But then come Saturday, Sunday, Monday, they've had time to, life went on and it wasn't the end of the world. So then when you come in and have to start up the MI conversation with them, got to kind of build that motivation back up to then be able to work with it. Yeah.
Yeah, that's well put. And sometimes we want to be working with the more calm and reasonable version of a person. But like you said, that also that tendency to minimize, to rationalize also creeps in.
Yes. Yes. Yeah. There's definitely sometimes you got to shut up and be the police is what I also say in trainings because it's not for every situation. As we delve into the crucial conversation about mental health and substance use, it's important to recognize the risks lurking in the shadows of these issues. This brings us to a critical message from our partners at the DEA, who are spearheading the One Pill Can Kill campaign. Now, this initiative is vital in raising awareness about the dangers of counterfeit pills and the alarming rise in overdose deaths linked to these substances. We're going to take a moment here and just listen to their important message to understand the risks and learn how we can all contribute to preventing these tragedies. Stay tuned for this crucial word from the DEA, then we'll jump right back into the engaging conversation with Dr. Emily Klein.
Saving lives means staying informed. Knowing the dangers of using fake prescription pills can help those you care about and keep our community safe. As a parent, educator, neighbor, or friend, we all play a role in building safe and healthy futures for ourselves and our loved ones. Do your part to take the first step today. Visit GetSmartAboutDrugs.com to access education, prevention, and treatment resources. Fake prescription pills laced with fentanyl are deadly. Be their protector. Be informed. Visit GetSmartAboutDrugs.com.
So I want to continue this though. Let's talk about the School of Heart Talks. Tell me more how it's evolved. So you've seen this gap in that, you're with that individual for 50 minutes and, every week or whatever their frequency is. But then, the rest of the time they're with their parents, their family, their caregivers. And so how do you go about sort of addressing that gap or that need?
Yeah, in 50 minutes once a week for adolescents who are really struggling is actually optimistic because many of them won't engage at all, right? Yeah. So many of them it's a hard no, and I never meet them. And then the parents, maybe call me back or call our intake coordinator back and say, sorry, I can't get them to come. I'll let you know if I ever get them to agree. Thank you for offering the appointment. And that's where the story ends a lot of the time. Or, maybe I see them once and it's just too hard for them. And there's a lot going on for kids, right? Like they're managing so much, including their own intense distress around whatever's driving that substance use, or maybe the substance use itself is causing that distress at this point. So I started developing this curriculum of sort of stripped down motivational interviewing that I felt like anybody who's interacted with a teenager or a young adult would get. And it's really built on the fundamentals of the practice, namely sort of accepting the limits of your control and even leaning into that. So reminding the other person of their autonomy and their responsibility, and really building up their confidence and their sense of being seen and understood through basic skills like not jumping in with scolding or advice right away, being curious, being calm, using reflections, using good, curious, open-ended questions, and then using our own advice, picking that moment to give advice really strategically and thinking hard about what you're going to say before you say it. I mean, those are sort of to me, the very fundamentals of the practice. And I feel like anybody could get them. And I designed a couple of research study protocols and got some funding from the National Institute of Mental Health. And where I live, the Massachusetts Department of Mental Health also kicked in because they were interested in the approach as well. And I ran some research studies, eventually involving 132 families, where I was able to meet just with the parents. I didn't bother these young people at all, but parents of adolescents and young adults who were having pretty significant mental health and often substance use problems, and taught those parents to use these skills over, it depended on, I ran the study a couple of different ways. Like I did one-on-one meetings with the parents over 5 hours, or I ran groups of parents who would learn together, and it would be 8 hours of group training to see, would parents be interested in this? And would they get it? Like, would they be able to do it? And also, what would the impact be on their family life, on their own sense of competence as parents, and on the level of conflict and stress in the household? So I did this with 132 participants and then followed people both before and after the training. We had a waitlist control condition so we could compare, and then followed up with people 8 and 12 weeks after I'd last seen them. So I wasn't just me. I had a number of therapists working on my team. 132 is a lot even for me. So so we followed up with them. We gave them the training, we said goodbye, and then we would follow up with them again 12 weeks later to see, not only did the training have any impact, but was it a durable impact? Sometimes, and I heard you talking about this with another one of your podcast guests, like you do something that feels good, but, a week later, you don't feel good anymore. It's not a lasting change. And that doesn't mean that thing isn't worth doing, but it means that you need to keep going or else the effect doesn't sustain. So in the research studies, what I found was really, really exciting and encouraging. The parents said that this really decreased their own personal stress level to have these strategies in their pocket. And they reported that their confidence was much higher, and their conflict between themselves and their child or their family member, who it wasn't all children, there's some grandchildren, some siblings as well, who came into the study, but whoever their loved one was, that they were worried about, that level of conflict really diminished. And that effect was not only a pre-post effect, but it actually sustained 12 weeks from when I'd even talked to anybody last. And in the conflict variable in particular, that outcome, so for things like stress, you can imagine like when you come to the study, your stress is high. We do the trainings, you learn the skills, your stress falls. And then it sustains 12 weeks out, which is really encouraging. But the conflict actually showed a different pattern, which was it fell. And then when we checked back in with people 12 weeks later, it had fallen again, kind of indicating to me that success builds on success, and that people were able to really use these skills to not just decrease conflict, but even improve those relationships over time. So it's kind of it's the double whammy of sort of decreasing the substance use and improving the relationships, which is always my goal.
I like it in the taking us off on a tangent, but talking about improving relationships, that's one of the things that I noticed once I started using MI, because I would use it, not also like just outside of work as a means to get my reps in, and realize that I had much better, deeper, more meaningful conversations with people. And it improved relationships so much more. And I mean, I'll put it out there. It makes me a better husband
Oh,
knowing
yeah.
MI.
Oh, definitely. I mean, and my husband has honestly overheard me talking about this so much that he's like very good at it. And I'm always like, oh, he's doing it. And I like it. It doesn't feel at all. People are always worried that they're going to feel like fake or condescending, but it never feels that way. Like it just is a really nice way to be talked to.
Right. And I had some previous coworkers that they, would come to me with a problem and I'd use MI, and in the middle of it, you're using that MI crap, aren't you? I'm like, well, yeah, what's wrong with that? Nothing. I just know what you're doing.
Exactly. Well, that's okay, right?
Yeah.
It's not dark magic, right?
Right.
I can't actually mind
Yes.
control anybody. It's just a framework for having conversation. So anyway, I realized I got kind of off on a tangent about the research study when you had asked me, like, what is the School of Hard Talks? So the School of Hard Talks is the curriculum of, what I started to call the School of Hard Talks in a joking way, like, this is how you learn to have a successful conversation about a difficult topic. And then, of course, working with a therapist is great, but it's also limiting, right? It's not scalable. I can only talk with so many people in my day. So I started thinking about, what are some other ways to disseminate this great information that's clearly benefiting people a lot. And so the book was an opportunity that arose from that. So I wrote a book sort of about all these skills and how to do them. And it has a lot of sort of characters in it. Some of them I made up. Some of them resemble people who were in the research studies or are sort of amalgamations of different people who were in the research studies. But really thinking about how to teach and illustrate these concepts without being in the room. Like, I can't be there. You're going to hold this book and get what you can out of it. So in the book, I sort of describe each of those principles that I, blew by in 30 seconds, like accepting that you can't control the situation, managing your anxiety about that, using reflections, helping people feel understood, and devote a chapter to each of those things and introduce the reader to kind of this cast of characters and show how their relationships change and their conversations change at that really granular level as they start using these skills.
Yes. And I'm curious. So when I do an MI training, actually, even when I first learned, one of the hardest things for me to do naturally are those reflections. It was so hard. And I see folks struggle with that all the time, and it not be turn it into a question or a passive aggressive statement. Putting you on the spot, but will you hit us with one or two tips as it relates to reflections?
Yes, I will. So I think the hardest part of doing the reflection, first, let's just talk about what a reflection is for people who don't know what it is. And then I want to talk about what makes it hard, because I think you're so right. So a reflection is basically just repeating back what you heard. And it sounds really simple, but it's actually really hard. So there's a couple different ways to do a reflection. You can do a simple reflection where you literally use the words the person used and say it right back to them. Or you can do a more complex reflection where you kind of paraphrase or even try and pull out a deeper meaning and offer that as your reflection. Or you can do like a feelings reflection where, maybe somebody's coming at you 100 miles an hour with everything they're upset about and why all your ideas are so stupid. And I might not be able to reflect all that, but I might just do a feelings reflection where I say like, wow, it sounds like you're so frustrated with this whole process. So that's a feelings reflection, or like a double-sided reflection where I'm really trying to point out to the person I'm talking to that they're saying things that are in contrast. And that might mean that they're ambivalent. So on the one hand, you don't think your drinking is a big deal. It seems very normal to you. All your friends drink exactly the same amount. And on the other hand, you're really freaked out about your academic suspension, right? So to use the example that you gave earlier in our conversation. So those are all different kinds of reflections, but essentially you're just making a very calm and controlled statement in a very non-judgmental way that just presents the other person's thoughts right back to them. What makes it hard? I think a couple things. One is that you don't realize, I think it's the self-awareness of realizing when you ought to do one, right? So recognizing that moment when you're encountering maybe some pushback, some resistance, and then realizing most of us in that moment flip into argumentation mode. Like, let me convince you why you're wrong and I'm right. And what we really should be doing if we want to use MI, and like you said, sometimes a cop just has to be a cop. And I agree with that completely. And sometimes a parent just has to be a parent. And that is totally true. And that's interesting. We should talk about that. But when you want to do MI, it's that moment when you're getting that push, that resistance, when you might most effectively use a reflection to change the course of the conversation. So one is just recognizing the moment. And the other is, I think, our own anxiety and need for resolution and control makes it really, really hard. So let me give you an example that just popped into my mind from a family that I worked with. And this is a mom who was really bought into these ideas. She really wanted to learn the skills. And her son was really struggling with some pretty big problems. And she was in a argument with him where he said, "You're embarrassed of me." And every thread of her being needed to shower him with love in that moment and show him that that wasn't true. And that's really hard to resist, right? Because a reflection in that moment could actually be very powerful, where you say, "You feel like I'm embarrassed of you," right? As opposed to, "Of course I'm not embarrassed of you. I love you. I'm just trying to help you." Right? Do you hear like where those conversations would diverge in the different direction you might take, and how one really prioritizes the feelings of the young adult at the center of concern who's having that substance use problem, and the other kind of immediately prioritizes the feelings of the parent who really wants to help. But their own stuff is like right in there. And so I think it's just really hard to do. It's hard to resist that pull, not to kind of set the record straight in that moment, but instead lean into your curiosity and keep following the person as they're talking about what concerns them.
So much wisdom, so much wisdom. And a little fun story as it relates to me and reflections. Um, I'm big on getting your reps in. Gotta practice, practice, practice. And so I would and still do practice. And one setting where I do that in the back of an Uber or a Lyft, having conversations. And my wife is always like, "People tell you the strange, why do they tell you this stuff?" And like, it's because I just throw a reflection out there. Give it a try. And I like to encourage folks, like, do that with a friend. When somebody's telling you about their day or a story or an experience, hit them with a reflection. Just see what happens. I dare you.
I always say when I get out of an Uber that I should bill them and not the other way around, because I do a lot of therapy from the backseat of an Uber. But it's true. It's like but I think it's because I do so many reflections that the conversation just goes in that direction. I think that's totally true. But I also think it's a really good point that people need to practice in, and this is like the last chapter in my book actually is all about this, that you need to practice when in a situation that doesn't, flood you with anxiety and dread. Because I mean, our own kids are always the Achilles. I mean, I know for me, like, it's so, I respond so differently as a mom than I do as a psychologist, like night and day. And I know this, and I have all the all the empathy in the world for the families I work with because I've been through it too, personally. And so I think like that is totally my advice. Try it in an Uber or try it. A lot of the parents I work with, they say, I'm practicing on my easy kid, which is like, if you have a family that has this constellation, you know exactly what that means, where you sort of have a kid who's a little more prickly and a little more challenging, and then you have kind of your easy kids. So practice on your easy kid, practice on your best friend, practice on your Uber driver, practice at work. I mean, work actually could be the end goal here, as you're saying. It's incredibly useful skill set at work. But definitely, I think you gotta practice and feel confident with it so that you can remember to use it in a situation where you're flooded with anxiety. And there's good neuroscience behind that too.
I can understand that. I haven't tried using MI with my daughter yet, but she's only 7 months old, so I think I've got a little bit of time.
It seems like you really don't want to go back to sleep right now at 3 a.m.
Right. I know. Tell me more about that. Let's unpack that. We're getting close to having to call this a wrap for now. Hopefully we'll have future conversation, but I'll say three questions left for you.
Please.
The first being to the parents that are listening, what would be their next steps to learn MI, to be able to start to incorporate, use, learn, get connected?
So I would really encourage them to check out the book. It's called The School of Hard Talks, How to Have Real Conversations with Your Almost Grown Kids. You can get it on Amazon or at your local bookstore, wherever you like to read. It's on Kindle. And check it out. I wrote it, so I'm a little biased, but I'm pretty hard on myself, and I think it's a great book. I really do. I'm so proud of this book. I love this book. It's full of, like I said, characters interacting with each other. And one thing I really love about the book is that, I wrote a lot of it almost like a play, like where, you just see what one person says and then what another person says. I'll present it one way or another way, and you can see how the conversation goes one way or another based on, for example, the use of a reflection at a strategic moment. So people can check out the book. They can also check out my website, Dr. Emily Klein, DrEmilykline.com. And just drop me a note if they want to get in touch with me, or if you want to hear more about this. I can, maybe give a webinar or come visit, if you want to learn more about this approach.
It's almost like you knew where I was going, because my second question would be to a listener who's maybe runs a regional prevention center or a local community level coalition. Like, this is amazing. I want to bring this to the parents in our coalition, in our community. What does that look like?
So I have done this lots of different ways with different folks. And of course, the last 5 years have stretched all of us with our imaginative capacity about what's on Zoom or what's in person. What is the best way to connect with people about different topics? But I've worked with lots of different prevention organizations. I had a wonderful time at the Utah Prevention Collaborative meeting a couple of years ago. I've worked with folks in Colorado who are running a local prevention collaborative up in the mountains. I've worked with the United Southern and Eastern Tribal Government around their prevention efforts. So just get in touch with me and we can brainstorm. I will tell you, I'm done doing 6-hour Zoom trainings. I'm never doing that again unless we have another pandemic. I can't do it. But I am happy to work with people. We can do train the trainer. I can come out and visit for a conference. Or we can just figure out what are some resources that maybe I can put together for your organization. In addition to the hat I wear as a professor at Boston University, I also have my own business. So I can work with folks in sort of creative ways like that as well.
You will meet them where they're at.
Right. Exactly. As we do.
Makes perfect sense to me. All right. Last question for you. Totally putting you on the spot because I did not prep you for this one. If you were to say to our listeners, if you're going to remember one thing from this episode, remember this, what would that be?
I would say, remember to try a reflection. I feel like we've gone over it. I feel like people might be feeling ready. Just try it, sometime today. When you stop listening to this podcast, the next person you talk to, or at some point during the day, when somebody says something, just say it back to them and see where it goes.
Marvelous. I'll second that. Absolutely. And it has been a delight. I'm going to be emailing you, wanting to stay connected, want to have more conversations about this because I love what you're doing. I want to help spread the wisdom that is the School of Hard Talks.
So
thank you
so
very
much, Dave. Thank you, Dave.
Yeah.
This is awesome.
Absolutely. It's been a pleasure, and stay well and keep on rocking.
Thanks. You too.
As we wrap up this episode, I want to extend a heartfelt thank you to Dr. Emily Klein for joining us today and sharing her valuable insights into the world of mental health and the transformative power of motivational interviewing. Her expertise and the pioneering work she's doing with the School of Hard Talks are not just inspiring, but also a beacon of hope in the complex landscape of mental health and substance use. And listeners, thank you for tuning in and being a part of this important conversation. We hope today's episode has enlightened you, offered you a new perspective, and equipped you with tools that can make a difference in your life and the lives of those around you. Remember, communication is powerful, and sometimes just one conversation can be the catalyst for change. If you found value in our discussion today, don't forget to share this episode with your friends and family. Let's spread the word and create a ripple effect of awareness and understanding. Until next time, stay curious, stay informed, and most importantly, stay connected because prevention is better together. Thanks for listening. We'll see you on the next episode.